Good evening, everyone. Am I audible? Just a slight correction. I'm a consultant pulmonologist in NMC Royal Hospital. I think the profile got mixed with somebody.
I know, it's written here. Anyhow, we are pleased to call you professor, no problem.
Thank you.
Thank you.
So after a fantastic talk by Dr. Tefel, let's try to catch up some clinically relevant topic on COPD. I'm going to present the updates on COPD. COPD is a very vast topic, and I've tried my best to keep it in 15 minutes. Let's see. So we all know that COPD is a major healthcare burden affecting nearly 300 million people worldwide and accounting for 3 million deaths annually, which makes it the third leading cause of death. And this is just an understatement because more than half of these patients are misdiagnosed or underdiagnosed. And this trend is going to increase because of the continued aging of population and continued exposure to the risk factors. This is an interesting diagram which shows how our lung function trajectory changes whether we are exposed to smoking or not. We all tend to gain our lung function until the age of 25. After that, it plateaus for some time, and then there's a gradual decline. But in a non-smoker, this decline never reaches the disability level. But if a person is a smoker, this decline is a steeper and a faster decline, causing disability by the age of 60, 65, which is still a young age. So it's a question asked by my patient, by my colleagues, that not everybody who smokes develops COPD. So what causes COPD? The concept of Getomics is trying to help to answer this question. Getomics basically explains how gene environment interact over the lifetime of an individual to shape up the lung function trajectory. It is opening a new area of understanding the pathogenesis of COPD and may lead to better prevention and treatment of COPD. Now, it is interesting to know certain etiologies of COPD. We are familiar with COPD related to smoking and related to indoor biomass exposure. We are also familiar with certain genetical types of COPD, which is alpha-1 antitrypsin related. But it is interesting to know that COPD can develop in individuals who were prematurely born or who were low birth weight. And also, chronic infections like tuberculosis or HIV can also lead to COPD development. It's important to know these etiologies because it increases our vigilance when we are dealing with patients with chronic cough, feeling of mucus in the chest, because a large number of small airway dysfunction can happen even at early stages of disease. In fact, pre-COPD is a condition. Now, a lot of people talking about it. Pre-COPD is where your patient's symptoms fits into chronic cough, chronic mucus production, but they have a normal spirometry. Now, coming to this screening questionnaire, it's a very easy to use questionnaire which you can use among patients who are more than 40 years of age, who have a history of smoking. And it's a very simple questionnaire, can be used in your clinic if a patient is more than 60 years of age, if a patient is a smoker and has chronic dyspnea or cough, should be referred to spirometry for ruling out COPD. Now, we still rely on spirometry a lot to diagnose COPD. Yes, it helps us in confirming the diagnosis of COPD. It also gives a prognostic value depending upon which grade of COPD we are dealing with. Most important is to know that when it comes to asthma, we do a pre and post bronchodilator spirometry. Means a patient comes to your clinic, you do a spirometry, nebulize the patient, and do a post spirometry, and then you compare the values. However, in COPD, we rely on post bronchodilator, FEV1 by FVC ratio. And if this ratio is less than 0.7, it confirms it confirms the diagnosis of COPD. So that means if a patient has already been initiated on an inhaler by your colleague or your patient comes with inhaler, you can directly do a spirometry. You don't have to withhold the inhaler like how we do in asthma. Large majority of our patients will not fit into the criteria of FEV1 by FVC post-bronchodilator value of less than 0.7. Those fall into category called PRISM, which states preserved ratio and impaired spirometry. Again, this category of pre-COPD or PRISM has been defined to pick up those patients who are prone for faster lung function declines. And data and research have shown that these patients have higher risk of cardiovascular mortality compared to patients with normal spirometry. So this, I'm sure you all are familiar with GOLD grade 1, 2, 3, and 4, which is based on the FEV1 value of post-bronchodilator spirometry. However, the treatment doesn't depend upon this grade. We need to know how bad is the patient's symptom, what is his symptom burden, and for that, we still rely on our age-old MMRC scale and the COPD assessment test score. The COPD assessment test score is again available in English and Arabic, can be used when your patient is waiting in the clinic, and it's a simple 8-point questionnaire which ranges from 0 to 5, the total score being 40. And if your patient is the score is less than 10, which suggests mild symptom burden, and higher the score, higher is the symptom burden. So based on the symptom burden and, most important, history of exacerbation, COPD is categorized into A, B, and E. Earlier we had A, B, C, and D, but now C and D has been merged to E category to emphasize the risk of exacerbation. So category A is those patients who are low symptom burden and low risk of exacerbation, whereas category B is high symptom burden, but again, low risk of exacerbation. And category E is irrespective of the symptom if your patient had more than 2 moderate exacerbation. Moderate exacerbation is a condition where a patient requires a short course of oral steroids or antibiotic, or more than 1 hospital admission leads to a severe exacerbation. So they fall into category E. So before we go to the pharmacological management, it is important that now the guidelines recommend to put emphasis on non-pharmacological interventions, which include smoking cessation, vaccination of your COPD patient, encouraging them to be physically active. When it comes to vaccination, we are familiar with annual influenza vaccine, we are familiar with pneumococcal vaccine, but now 2 more vaccines has been included, which is your RSV vaccine. If your COPD patient is more than 60 years of age, they need to have RSV vaccine, and if the patient is more than 50 years of age, even zoster vaccine is recommended. If your patient does not have history of receiving pertussis vaccine in their adolescence, even Tdap vaccination is recommended. Now, coming to the pharmacological medications which we have, Group A is those patients who are very low symptoms, not very dyspneic, no risk of exacerbation. You give them a simple bronchodilator. Group B usually prefer if a patient's symptom is more, so you prefer 2 medication, which is long-acting beta agonist and long-acting muscarinic agent. And again, in Group E, the steroid use in COPD has been discouraged because of increased risk of pneumonia and infection. So even Group E, the guidelines recommend try to use long-acting beta agonist and long-acting muscarinic agent. Use steroids only if you have certain biomarkers, especially eosinophil positive, especially more than 300. So this is very important slide. So if your patient has history of more than 2 exacerbation, eosinophil counts are more than 300, or history of similar to asthma, allergy, go ahead, use inhaled corticosteroids. However, if the patient had history of recurrent pneumonia, history of TB, or eosinophil count is less than 100, it is strongly discouraged to use inhaled corticosteroids in COPD. In between, so guidelines favor go case by case and decide if you want to give steroids to your patient. Now, like asthma, even for COPD, now it's recommended to give a treatment chart to your patient, how to escalate or de-escalate the medication for the COPD patient. So if a patient is stable, doing well on treatment, the guidelines recommend de-escalating their bronchodilators from combination inhaler to maybe a simpler inhaler. So this is very promising because earlier, once a patient of COPD was started on an inhaler, the concept was they will continue to be on this inhaler. But now there is an encouraging approach. You can de-escalate if the patient is stable. Just showing you the examples of commonly available inhaler. We have Ventolin, we have Atrovent, and there's Atrovent Comp. Among the LABA/LAMA, we have all once-a-day acting inhaler. We have Spiriva, Altibro, which is a combination of indacaterol and glycopyrronium, again, once-a-day inhaler, and Anoro, again, once-a-day inhaler. Triple therapy, you have Trelegy, Trimbo, Breztri, and Enerzair. When it comes to the metered dose inhaler, it's always encouraged to use a spacer for the patient when you're giving an MDI, because these are elderly patients we are talking about. It's difficult for them to coordinate the inhalation and pressing the inhaler at the same time. And when you're giving a dry powder inhaler, make sure that patient has enough inspiratory flow to generate enough inspiration to get the powder deposited in their lung.
Okay.
So what if your patient is on LABA ICS? This is a common scenario. Your patient might be already on LABA ICS, which is a commonly prescribed inhaler, sometimes due to insurance-related issues, sometimes because they are not able to tolerate anticholinergic medication. What should we do then? So guidelines do recommend that if your patient was stable, if there was a history of exacerbation, which was well managed by LABA ICS, you can continue the treatment. However, if the symptom burden is more, shift your patient to triple therapy combination. Now, during the time of follow-up, if patient continues to exacerbate, your patient is already on a triple therapy inhaler. What is next? So if a patient's eosinophil count is more than 300, now biologics are approved for COPD. We have dupilumab, which has been approved in UAE as well. If the count is less than 300, less than 100 even, then either you can go for azithromycin. We give immunomodulator dose of azithromycin. It reduces the exacerbation, but there's always risk of drug resistance. Baseline audiometry and ECG is recommended when you're giving a long course of azithromycin. Roflumilast in some country people are using. We do not use it that much. It's a phosphodiesterase inhibitor. And now the research and several trials have shown that triple therapy, single inhaler triple therapy, has shown to reduce mortality in COPD. That's the only pharmacological intervention that has shown to have mortality benefit. The other non-pharmacological intervention which has shown to reduce mortality in COPD is smoking cessation, pulmonary rehabilitation, LTOT. And just few points to emphasize since I have only 3 minutes left. So when it comes to oxygen therapy, we all know that patients with severe COPD with baseline hypoxia will benefit with low flow of oxygen given for 16 to 24 hours a day. However, for moderate COPD or COPD with ambulatory hypoxia, it does not lead to any improvement in exacerbation or mortality benefit. The criteria for oxygen still remains the same. If a patient has resting hypoxia with PaO2 of less than 55 or SATs of less than 88%, they are the candidate for long-term oxygen therapy. Or if the PaO2 is between 55 to 60 with signs of right heart failure, again, they are a candidate for long-term oxygen therapy. The COPD treatment landscape continues to evolve. We have a lot of upcoming biologics. In fact, in addition to dupilumab, even mepolizumab has got the FDA approval for use in COPD. However, in UAE, it is still awaiting the regulatory approval. Ensifentrine is the newest phosphodiesterase inhibitor. It's a dual phosphodiesterase inhibitor which has bronchodilator and anti-inflammatory effect. It's a nebulized medication, still awaiting the regulatory approval in UAE. And that brings me to the last slide. So the realization that environmental factors can contribute to COPD, that it can start early and affect young individual, and conditions like pre-COPD and PRISM, they open a new window and opportunity to prevent for early diagnosis and appropriate treatment of COPD. Eosinophil correlates well in type 2 inflammation in COPD, and biologics have role now in treating this type 2 inflammation. The secondary outcome of large trials support that single inhaler triple therapy reduces mortality in COPD. And last but not least, additional data is recommended regarding the use of electronic cigarettes to aid smoking cessation and the long-term risk related to electronic cigarettes. Thank you.